and recognizing that we're a changing industry where we can't sit back and wait on those things anymore, or if the doctor writes the order, then we'll get the service. So we want to be much more thoughtful about being easy to use, easy to access, and responding to the changes in those areas. Provider alignment, it's our belief that the healthcare organizations that are successful over the next 10 years or so are going to be the ones which are best at collaborating and engaging with clinicians, with physicians. We were talking at our table about the phenomenon of hospitals now employing so many physicians, and that's changed the nature of the medical staff. In addition to employing physicians, we now have hospitalists, right? So we have internal medicine doctors that do nothing but manage inpatients. And we have, of course, ER doctors, right? But what that means is that the family practice or internist in the community doesn't go to the hospital anymore. They don't go to the hospital. They admit the patient, and Dr. Kimball, one of our hospitalists, manages the patient. Now, from a clinical delivery point of view, there's tremendous advantages to that. Not the least of which is information technology is complicated, using the medical record is complicated, pharmaceutical management, inpatient acute medicine is different than primary care medicine. In the days gone by, your primary care doc, if you went to the hospital, he or she got out of bed earlier that morning, went to the hospital at 7 o'clock, checked you, looked at your labs, wrote some orders, talked to the nurses, how you doing? End of the day at 5:30, came back, looked at you, checked it. That's how we delivered medicine, right? And so that works when you don't have all that many tools or options, right? When there's not that many choices to make. But now, there's hundreds of choices around medication and treatment and diagnostic imaging and therapeutic stuff. So we have moved as an industry to doctors who specialize in that. But it changes that relationship. Yes, you had a question?
Where does I'm not sure what the name of it is. Is it concierge medicine?
Yes.
Where does that fit into this?
So in our community, it's called MDVIP, I think it's called, and there's about 4 docs in our community that have that model. So that's another kind of primary care model where instead of having a panel of, say, 2,000 patients or 2,500 patients in your panel, and then your patients come to you when they need to, and they call you, and they make an appointment or an annual checkup or whatever it is, right? That's how it works typically. In a concierge practice or an MDVIP practice, what you do is you move the panel from 2,500 to 450 or 500, and each one of those people pay, say, $1,000 or $1,500 a year to be on that panel. So the doctor's panel shrinks down significantly, and it allows he or she to spend more time and be more engaged with you. Now, the benefit of that is sometimes it's frustrating to go to the regular doctor and you have, 9.5 minutes or 15 minutes or whatever, and so that can be frustrating, and the doctor's managing lots of people. That's the upside of it. The downside of it is most people can't pay $1,500 a year for the privilege to go to that doctor. And so recently, when that happened in our community, we had 4 or 5 doctors go to that model. We all of a sudden, just like that, we had 9,000 people without a physician. Right? Because we went from 2,500 to 450. So 2,000 per doctor said, I need a new primary care doctor. So it's one way to provide primary care. It won't be the solution, but it's one solution. It's like, being able to send your kid to private school. If that's what you want to do and you can afford it, knock yourself out.
Sounds like elitist medicine.
Well, that's one way to think about it. I tend to look at it as there is a continuum of ways to, what's elitist medicine is having people with no coverage at all. That's the most salient to me, is, you don't have coverage, you're out of luck. So, but our industry in this country, the way we have chosen to set up healthcare is that way. That is the way we've chosen. So now we're just trying to deal with it. Anyway, that's provider alignment, getting more engagement. You know, when you all think about the finest in medicine, you think of Mayo Clinic, Cleveland Clinic, Marshfield Clinic. You think about organizations that have been clinically aligned with physicians for many, many years. And we think that's the right model, not just from clinical leadership, but also from how should we be organizing? How do we deliver services? What does it mean to open up our practices? How do we make those decisions? How do we create an environment where physicians that can go anywhere in the country want to come here because they like this community and this medical community? That takes physician leadership, not just administrator types like me. Okay, we're coming home. So here's what's on the front burner for me right now and what I'm thinking about right now, because those ideas around destination health, those are our North Star for the next 10 years or so. But right now, the things I'm thinking about is we have got to start doing a better job with mental and behavioral health. And we're not alone in that. Almost every community in this country struggles with this. For whatever reason, over the years, our country decided to bifurcate mental and behavioral health and clinical medicine and physical health. And as much as possible, let's not mix them up, even though they're inextricably related. And any primary care physician can tell you that of the 20 patients he saw that day, 10 of them had some sort of situation going on with their family, with depression, with anxiety, with substance abuse, with dependency, with something, where a mental health professional who is alongside of her as a primary care clinician helping that patient would be advantageous. We need to get rid of the silos between us. And we just need to do a better job at Lawrence Memorial of how do we take care of all these people coming into our emergency room.
Oh, have hospitals considered buying private practices, counseling practices?
We have, we already employ one psychiatrist. We're adding a second one, and we have advanced practice nurses. You know, they haven't in the past, and the reason they haven't, you know, I'm an economics major undergraduate, so I tend to return to those concepts. The reason hospitals haven't typically employed psychiatrists is because they don't admit to hospitals. And so they're not an income generator for a hospital, they're just an expense. They do private practice, you come in, they manage your medication, but they don't order MRIs and CTs and do surgery and do all the things that generate income for us. And if we only have so much money to invest in physicians, we're going to invest in a general surgeon, not a psychiatrist. Okay? Make sense?
No.
Does it make sense?
No, it doesn't make sense because that means that there's a whole slice of this larger community that you think you're holding yourself responsible for, who are not being appropriately served.
Right. So as you, I agree with you. So as you embrace a broader notion of what's the role of a hospital,
Right.
then I would agree with you. Historically, the role of the hospital has not been the community's health. It has been, we are here to care for you when you need us. That's been our role. That's been the model. And financing and delivery system is changing that notion. You know, the role, who gets paid in the past for that? Insurance companies. Insurance companies, historically, are the ones who have been paid to take the risk on the health care of everybody in their pool, right? But that's changing, and so I don't disagree with you, but if you're in an organization, any of us who are in a business of limited resource, and you're responsible, so it's not our hospital either, it's the community's hospital, we're responsible for the fiduciary operation of that hospital, we need to make the decisions that keep that hospital intact. So now we're broadening what that definition is, and we might get paid differently to do it too.
If the hospital had a mental health unit, that might be different.
It might be, and there's a lot of controversy about that. My understanding, when we closed the mental health unit in 2004, we had a 16-bed mental health unit. We had an average daily census of 3. That's very difficult to make that work. The challenge in mental health, and the reason this is up here, is not the problem around voluntary admission for mental health illness. There are lots of good options for voluntary admission for inpatient mental health. The problem that we're having in Kansas and in many other communities, but Kansas specifically, is around the state cutback in mental health at Osawatomie and Larned. And so we have patients waiting in our emergency room for 3 days, 4 days to get into Osawatomie. So that's a problem. It used to be 6 hours or 8 hours. The second part of the problem is it's the continuum post-crisis. So we're working in this community on how do we better handle the crisis of mental health, right? And that's important. When someone crashes with their substance abuse problem, they quit taking their schizophrenia medication, whatever happens, and they're in crisis, then you need a safe place that you can stabilize them and care for them and get them ready for a warm handoff to then the ongoing management of mental health, right? The problem in our community and in almost every community in the country is the lack of adequate resource around the ongoing management of those patients. And that's where we're engaged with Bert Nash, with Heartland, with the county, with the city, with healthcare access, about how do we address this continuum together. It's not the hospital's problem or Bert Nash's problem or the county's problem. It's our problem. So, secondly, I want to look and see how do we make our services more convenient. You know, we have physical therapy in our hospital. It's a fabulous group of providers, extremely well trained, a very good service. It sits on the second floor of our hospital. So if you've ever, and if you have physical therapy, you might be going 3 times a week for 6 or 8 weeks, right? If you parked at our hospital recently, that's a bummer. Nobody wants to park there 18 times over the next 2 months. And it's not convenient. When somebody else opens up a physical therapy, they do it in a strip mall and you park 25 feet away and you walk in. So we need to think about that in a lot of ways. Dating and hanging out. We're sort of in the mode of, you know, nowadays young people, they don't date. They just hang out together for a little while. So I'm trying to be him. We're starting to court other health systems in the region to find out what are they like. Are they a good partner? Are they someone that we can work with in order to create that scale we were talking about before? Do we share a sense of mission and culture together? Are they heavy-handed? Are they collaborative? Because ultimately, as the delivery system changes, we're going to need to have a partner. Okay. Other than that, we're not doing much. But
Russell, how much longer can you stay?
I've got some time for questions. I'm happy to do that.
All right.
Well, it's very interesting, but in our family's experience with the hospital, my wife used to work there, and we've been here a long time and used the hospital. I'm very struck by a recent hospitalization of my wife, how almost everybody at the hospital was openly concerned about the quality of their service.
Yep.
It was very striking. I mean, I can remember 20 years ago going to the hospital where that sort of thing never happened, including aftercare calls from the hospital.
Right.
It's very, very different.
It is. I mean, there's a lot of really good things happening in healthcare. And you know, like so much of news around we see the negative, but we have in ICUs where we go 6 months without a central line infection. That was unheard of 10 years ago. In fact, 20 years ago, if you would have told an intensivist or a pulmonologist that, you know, you really want to run the ICU without a central line infection, they would have said that that's not possible. It's impossible. That's just part of healthcare. And it's not part of healthcare. And so healthcare is rapidly moving towards a much higher clinical safety model, zero tolerance model. And so I'm glad to hear that. We are trying to figure out, after years and years and years of being able to have this veil between us and the patient, where we just got to do whatever it is we did, and you, thank you very much, or you didn't like it or whatever, but it didn't much matter. It's different now, and it should be different. Other questions? Anything you want to take offense with? Yes?
When the new city manager was here, he's just as competent and energized as you are.
Yeah, he's a good man.
I asked him, what I'm going to ask you, what do you do to decompress at night? You've got umpteen ideas in your head floating all the time.
We do. You know, I am just so fortunate that I had an amazing childhood. And so I don't carry much anxiety or stress with me. And, you know, I've been in this industry for 33 years. And I sleep every night. And probably that's a better question for my staff, who inherits all my ideas and actually has to make them happen. You know, but you know, I think the real answer to your question is how do we stay centered on what matters and what our principle is. You know, and if we stay centered on, despite all of the dialogue around payment systems and infrastructure and scale and economics, if we stay focused on that we're ultimately about the health of that individual patient who comes to us and this community, then the rest is more window dressing. Yes?
I was intrigued by your comments about people who have, what do we call it, $2,000 worth of
Deductibles.
Is that a trend in insuring, and from your perspective, is that good or bad for me?
It's absolutely a trend. So what happens as healthcare gets too expensive, right? So employers are facing double-digit premium increases every year. Unsustainable, right? We had a little blip during the first 4 or 5 years of the Affordable Care Act when the costs came down and all that. But generally, employers are facing that. So what happens if you're an employer and you're looking at a premium increase of 12%, it's the second largest expense item on your income statement, then you say, okay, Mr. Broker, let's start looking at different plans. So you start looking at it, well, I can do this plan that moves the deductible from $250 per individual and $500 per family to $1,000 per individual and $3,000 per family, and your premium cost won't be a 12% increase, it'll only be a 3% increase. So what happens is we're shifting the risk to individuals. But unfortunately, most individuals, most of us, no way can we shoulder $3 or $4 or $5, much less $10,000. And there's lots of $7, $8, $9, $10,000 deductible plans.
So what happens?
So they come to the hospital and they get a bill, or worse, they avoid care because they don't want to pay the out-of-pocket until they get really sick, come to the emergency room, need surgery, generate a $25,000 bill for which they're responsible for the first $5,000, and they can't pay it. And so we then shift that in the next budget year to our charges. So our charges go up. That translates to the insurance companies for higher premiums, and they go back to that employer and say, oh, you know, your premium has to go up another 9% this year. So that's sort of the cycle we're in. And that's why we've gone from, you know, 8% of gross domestic product to 17.5%, coming up on 18%.
Is that $5,000 shifted over to a collection agency?
Yeah, but we collect about 9% of the dollar on self-pay.
Is that right?
Yeah.
Is there any chance that insurance could be taken out of employers? In other words, like Medicare?
Right, Medicare for everybody.
Yeah.
So the reason one of the ways that we're different, great question. One of the reason we're different, as no other Western country in the world, none, have employer-based health insurance. None. The reason we do is because during World War II, we put wage freezes on. And employers, in order to keep and attract labor, said, oh, well, let's provide some benefits. So they started providing health insurance back when health insurance was cheap. It was cheap. So we created the employer-based health insurance model. Now, are there any insurance people in the country? So here's my opinion about insurance. Insurance is an actuarially driven commodity. And the best way to insure is to have the biggest group covering your risk. So one of the reasons that's scary right now for changes to the Affordable Care Act, because if you eliminate the individual mandate, the people who will leave insurance first are the healthiest, because they don't need it. Young people and healthy people. So what happens to your risk pool? You've just removed from your risk pool all these people that you make money on, and you've kept in your risk pool all the people you'll lose money on. So what will happen? Insurance rates will go way up. So my personal opinion is, if you look at how much it costs to administer insurance, I think these are about right, but Medicare costs around 8.5% to 9% to administer. Commercial insurance is about 21%. And so if you multiply that by 150 million people, you begin seeing that maybe we could think about it that way. But it's just not the appetite in our country. We just don't, we're fearful of that.
And
Yes.
if we could pull in veterans' expenses and motor vehicle expenses
Right.
and disability. And
Right, and not have
all
5
of
different systems that are confused. You know what you're talking about. Yeah, it's confusing and it's difficult. And yeah.
Is the socialized medicine thing that scares people?
Yes. And it's like so many things, it's the misunderstanding of how it works. So we don't have to privatize healthcare to have insurance for everybody, right? So, in the United Kingdom,
I'm from the United Kingdom. We have a good.
yes.
Good.
And in the United Kingdom, the model is they not only hold the insurance, but they also employ most of the providers and they own the hospitals. The state does, the government. But in Germany, that's not true at all. In Germany, the state provides coverage, but the hospitals and the physicians are all private. They just accept payment from that single payer. And so, you think about the implications are staggering. We deal with 30 different commercial carriers, all with different contracts, all